Good morning. Hope everybody's had a good breakfast. So the only financial disclosure relevant here is my work at Up to Date. Just to give a quick overview, in the course of this talk, I wanted to talk a little bit about pathophysiology, hit some of the points that I think are often unemphasized. We'll talk through the talk about the diagnostic approach to sodium disorders, the clinical sequelae, and separate out in particular the effect of acute versus chronic hyponatremia. And we'll talk about management of hyponatremia. And we'll end up with a shorter section on hypernatremia and polyuria, the differential diagnosis list, and the diagnostic approach and management. So all the renal fellows at the Brigham are given a list of movies that I want them to watch during their clinical year. It's surprising how few millennials have seen Dr. Strangelove, which of course has that classic issue talk about the water is the source of all life and talking about precious bodily fluids. But I always think of that in terms of sodium disorders, because really this is a disorder of water homeostasis rather than predominantly sodium disorder. Just to go through the physiology, vasopressin or AVP or ADH, antidiuretic hormone, regulates water homeostasis and osmolality primarily. So with the water excess, osmolality decreases, plasma vasopressin declines. You get an increase in water excretion by the kidney, and that normalizes osmolality. There's an osmotic response curve in terms of the release of vasopressin, which we'll talk about, and a thirst curve as well. If you have a water deficit, you get an increase in osmolality that stimulates plasma vasopressin and also stimulates thirst, and that reduces renal water excretion and then helps normalize your osmolality. If we think of the nephron, it's really important to remember that the renal concentrating mechanism involves the cooperation of the entire nephron. So not just the distal nephron, but the proximal tubule, but also the vasorecta that set up this countercurrent gradient in terms of removing water and removing solutes and concentrating the inner medulla. In the setting of water diuresis, you end up with a very low urine osmolality as you get to the end of the nephron. In the setting of water deprivation or antidiuresis, you have an increase in vasopressin and a maximally concentrated urine. I like this slide. It just sort of reminds us that there is a physiology, a molecular physiology of water reabsorption along the nephron. And again, this theme that it's really the entire tubule that plays a role in water conservation. So within the proximal tubule, there's apical and basolateral aquaporin 1, which was the initial water channel that was discovered in red cells. And passive water exit across the proximal tubule, but also in the thinnest descending limb, where there's also aquaporin 1, increases the concentration of sodium chloride within the tubule. And then in the thin ascending limb, you get paracellular sodium absorption and transcellular chloride absorption through a chloride channel, CLCK1, and that helps with the concentrating mechanism. But then really the driver of the concentrating mechanism is the thick ascending limb, when you have ATP-driven reabsorption of sodium through the NAKCl cotransporter and ROMK. And that's a primary driver, or the single effect of the countercurrent multiplier in terms of increasing interstitial sodium chloride and ultimately urea as well. Finally, when you get to the collecting duct, you have aquaporin 2 and 3 and 4 that play a role in water absorption across the apical and basolateral membrane of the principal cells. And there are vasopressin-activated urea transporters that play a big role in what's called the Berliner hypothesis, or the Berliner phenomenon, where you reabsorb urea as part of the countercurrent mechanism, but also to avoid having urea being an osmotic diuretic that reduces your ability to concentrate the urine. Ultimately, though, the final common pathway for the disorders that we're talking about today is the principal cell in the collecting duct. And there you have vasopressin V2 receptors that turn on adenylate cyclase. that turns on protein kinase A that phosphorylates the water channel and induces movement of these vesicles to the apical membrane. Then when you have this interstitial hyperosmolality, you drive water absorption across the collecting duct through apical aquaporin 2, but also basolateral aquaporin 3 and aquaporin 4. So what does this have to do with clinical medicine other than helping us understand what's happening at the bedside? Clearly now we have vasopressin antagonists that can antagonize the effect of vasopressin in hyponatremic states. We don't really have a lot in terms of agents that turn on water absorption. Until recently, you'll have to excuse my pun, but fluconazole was reported in May as being a drug that seems to activate water transport in the collecting duct through many mechanisms. It inhibits these Rho proteins that play a role in the cycling of vasopressin responsive aquaporin 2 channels, and it increases the abundance and phosphorylation of aquaporin 2, so it turns on water transport. So think of that next time you see somebody in the clinic. Maybe fluconazole may end up being something that we're going to be using for nephrogenic DI. In terms of the overall physiology, it's important to remember that there are two things that are regulated by vasopressin. One is osmoregulation and the other is volume regulation. And I think this is where a lot of the confusion comes in terms of sodium disorders, because vasopressin does play a role in reabsorbing sodium in the nephron and defending the extracellular fluid volume. In terms of what's sensed with osmoregulation, here we're sensing plasma osmolality. Here we're sensing the effective circulating volume or the arterial perfusion pressure. This is sensed by the hypothalamus, as we'll talk about. This is sensed by many different baroreceptors in the carotid sinus, the afferent arteriole, and also in the atria of the heart. Here the effectors are vasopressin and thirst. Here it's the sympathetic nervous system that gets turned on to increase sodium absorption and also increase vascular tone. The renin-angiotensin-aldosterone system, which has so many different effects on salt absorption in the kidney, but also vascular tone. ANP and BNP get turned off or turned on depending on the extracellular fluid volume. But also vasopressin is turned on in the setting of a low effective circulating volume. And teleologically that makes sense because you want to increase renal reabsorption of sodium, and vasopressin through V2 receptors does that. But through some of the other receptors for vasopressin, it also increases vascular tone and blood pressure. What we're affecting here is urine osmolality and water intake. Here it's urinary sodium excretion, but also vascular tone. So again, the same theme. There are three flavors of vasopressin receptors. The V1A receptor is the one that's sort of everywhere. Vascular smooth muscle, where it plays a role in vasoconstriction. It also plays a role in baroreflex and blood pressure control. And then, of course, the V2 receptor that's in renal principal cells, thick ascending limb cells, also in vascular endothelium, where it controls release of von Willebrand's factors. But that's the one that we think of in terms of water reabsorption and sodium disorders. It's really important to my mind to think of hyponatremia as really a CNS disorder, where there's something that's gone awry usually with central osmoreceptors. And these receptors are in the organum vasculosum of the lamina terminalis. I always write that down on the slide so that I can remember how to say it, or the OVLT, and also the subfornical organ. And these osmoreceptors feed forward into the posterior pituitary, and the cells that make vasopressin also have osmoreceptor mechanisms as well. And then in response to changes in osmolality, vasopressin is synthesized in the posterior pituitary and released in the posterior lobe of the pituitary. So that happens in response to changes in osmolality. But the key point is that these response curves are modulated by extracellular fluid volume. One of the most potent dipsogens that you can give a rat, for example, is to infuse angiotensin II into the brain, and they just go nuts with thirst because that's turned on, as is vasopressin. So there's regulation of these osmoreceptor neurons at a very, very minute-to-minute basis. If you take somebody and salt restrict them and make them hypovolemic, the point at which you start to see vasopressin appear, the set point starts to go down. So you'll start to see vasopressin appear at an osmolality of 270, and the response curve is much steeper. If, however, you give somebody a surfeit of sodium and increase their extracellular fluid volume, you tend to flatten the curve and you change the abscissa to about 290 or so. And that really is what underlines the physiology of hypovolemic hyponatremia. It's not that you're taking off 2 liters of fluid, which there is a vasopressin response. It's really that you're moving from this curve to this curve, and that occurs very quickly when you give somebody saline and you turn off the vasopressin secretion, and vasopressin has a half-life of only 10 minutes or so. So this physiology is very dynamic and changes, and this key issue is that when we do something to these patients with hyponatremia or hypernatremia, we are changing this physiology on a minute-to-minute basis, so these patients change over time. One of the other issues, if you look at older textbooks, they say that the thirst mechanism is actually a little less sensitive than vasopressin, and it's shifted to the right a little bit. If you do very careful monitoring of thirst in humans, however, you see that the curve is exactly the same as the vasopressin response curve. So as you increase osmolality, and thirst starts to gradually increase to a really high level once you get to hypertonic ranges. That has a very important consequence for hyponatremia, in that typically you need to have an intake of water to generate hyponatremia. It always bothered me as a fellow, if these patients are hypotonic, why don't they just stop drinking and then reset their serum sodium? Well, in actuality, again, this theme that it's a central osmoreceptor defect in many of these patients, and the osmoreceptors that control vasopressin overlap with the centers that control thirst. And they're turned on inappropriately in patients with SIDH. So their thirst curve is also shifted to the left, as is their vasopressin response curve. So there's an abnormality in thirst in many patients that we see with hyponatremia and SIDH that plays a big role. And it also underlines that it's really hard, why it's so hard to reduce the water intake in many of these patients, because they're actually still thirsty at relatively low plasma osmolalities. So if we see a patient at the bedside, you all do this instinctively, but we have to just go through and make sure we're not forgetting certain aspects of this evaluation. First of all, in the H&P, medications are really critical, of course. And I'm sure you all appreciate as practicing nephrologists that SSRIs have sequentially been the most common contemporary cause of SIDH. So every SSRI to some degree is associated with hyponatremia. Similarly, serotonin agonists also cause hyponatremia. Some of these mixture mechanisms, these various drugs that have different mechanisms other than uptake inhibitors, also will cause hyponatremia. You want to know what's happened to this patient. Have they had pituitary surgery in the past? So do they have secondary adrenal insufficiency? You want to know critically, though, what on the review of systems, do they have any symptoms that are attributable to acute or chronic hyponatremia? Chronic, of course, is hyponatremia that's been there for more than 48 hours. And you want to get some idea of what, are there symptoms that are suggestive of a cause? For example, profuse diarrhea leading to hypovolemic hyponatremia. In terms of the exam, the key issue is the presence or absence of hypovolemia or hypervolemia. I tend to feel very strongly that this is not a very precise assessment of volume status, and you really need the urine sodium as well. I'm not a big fan of skin turgor in those above the age of 5 as a very good indicator of hypovolemia. So you want to know their orthostatics. You want to have somebody look at the JVP, these sort of harder data in terms of hypovolemia. In terms of hypervolemia, what's their JVP? Do they have peripheral edema? Do they have pulmonary edema? I think you all do this instinctively. One of the major mistakes that can be made is to not measure serum osmolality in these patients. You really need to exclude pseudohyponatremia. You need a serum osmolality. You need the urine osmolality. If it's less than 100, this is very diagnostic or suggestive of primary polydipsia. Greater than 100 suggests some reduction in water excretion. Clearly, if you have somebody who has a urine osmolality of 800, they have really maximal urinary concentration. The patients in between, so somebody that comes in with SIDH and they have a urine osmolality of 250, usually if you go back to the bedside, they do have a pretty generous water intake. So there are people that have both, a high level of vasopressin and some increase in their water intake. In terms of the urine sodium, if it's less than 20, that suggests effective or true volume depletion. You can't tell without that history, is this heart failure or is this hypovolemic hyponatremia? Clearly the exam also plays a big role. And greater than 20, that suggests euvolemic causes or renal salt wasting. It's important to remember that not everybody has read the textbook, as they say. So you may have an elderly patient that has a urine sodium of 25, and for them, that really is indicative of hypovolemia with an aging kidney that does not reabsorb salt as much as it would have in the past. So here's a quick case just to do a segue into one particular cause of hyponatremia. This is a 63-year-old man, a relapsed alcoholic with greater than 12 beers a day. He'd been to his PCP 2 days before, was found to have a serum sodium of 115 and told to return to the ED. On exam, he's barely rousable but responds to command slowly. Supine blood pressure is 124/67 with a heart rate of 80. Standing, his pressure actually goes up with a heart rate of 114 and then 105/84 after 5 minutes with a relative tachycardia. Sodium is less than 110, potassium 4.8, chloride 73, bicarbonate 27, BUN 9, creatinine 0.8, urine osm 227, urine sodium less than 20, serum osmolality 236. So just in case you think that I made this case up, this was a case about 10 years ago from the Boston VA, and this is exactly what we saw in this particular patient. So which of the following is the most likely cause of this presentation? Beer potomania, pure hypovolemic hyponatremia, SIDH, or polydipsia? So just to go back, there's this suggestion that maybe he's a little bit volume depleted. He was initially hypertensive when he stood up, but then he had a slight drop in his blood pressure, and he clearly had an orthostatic tachycardia. So there could be two things going on here. He could, in fact, be hypovolemic, or this could be something else. Clearly, however, this is a patient with beer potomania. He actually told us that he only drank 6 beers a day the first day we took care of him. The next day, he admitted he took 12 beers. By the third day of hospitalization, he did admit to drinking at 2-4 per day. So this brings up this question of low solute hyponatremia, which I think really does need to be considered separately from other forms of hyponatremia, because this is probably vasopressin-independent hyponatremia. Typically, this is patients with a history of alcohol dependence with a suspicion of recent drinking. They typically have low urine osmols. Here, the urine osmolality was relatively generous. It was 220. They have a rapid initial correction with IV saline and with eating. And in this particular patient, he was euvolemic with slightly orthostatic, confusing orthostatics. It's important to remember, though, that if it's hypovolemic hyponatremia or low solute hyponatremia, they're both at risk for overcorrection, and you need to take that into account when you treat them. So beer potomania is a vasopressin-independent cause of hyponatremia. Remember that free water excretion in the urine requires a minimum amount of solute. Beer provides carbohydrates that can sustain, but with no salt or protein. So it has a sodium concentration of about a milliequivalent per liter and no protein. So it really generates minimal urinary solute excretion. And if you combine that with the high free water intake from the beer, patients become hyponatremic. There's no vodka potomania. So you need the extra water that comes with the beer as well. Classically now, urine sodium and osmolality, classically you have a low urine osmolality, low urine sodium, but it's important to remember that not everybody has that. So here's a really nice case review of many different cases of beer potomania and low solute hyponatremia. The key point is here in the urine osmolality. The urine osmolality, some of them were classically less than 100, but many of them were like the patient that I described. They were much more generous. So what's really important in these patients is the clinical history and the clinical suspicion of low solute hyponatremia. Clearly, beer isn't the only cause. There are patients who are on extreme diets that are very low in solute that can also get into this syndrome. Again, why does this happen? Well, remember that you need to be able to excrete, you have to excrete water with a solute. You can't excrete complete free water. So if you look at solute excretion for people that are excreting 300 milliosmoles per day of solute versus 600 versus 900, at 900 you can really generate much more free water clearance than you can in somebody that's only excreting 300 milliosmoles per day of solute. So back to the evaluation of hyponatremia. Further testing, I think we always check a TSH, although really it's only in the extremes of hypothyroidism that you see pure hyponatremia due to hypothyroidism. Random cortisol is important to look for primary or secondary adrenal failure. We'll talk about secondary adrenal failure in a minute. Also check on other indices of pituitary function if hypopituitarism is likely. If you think that primary adrenal failure is likely, you may do a concentropin stimulation test. Everybody should get a chest x-ray. If negative, however, in a high likelihood of small cell carcinoma, get a chest CT. So every smoker that I see with hyponatremia, even if it's not clearly SIDH, I will try to get a chest CT. Remember that small cell carcinoma is often very central, so it can very clearly be missed on a chest x-ray and you need a chest CT. To really fully evaluate patients with SIDH, they may need a head CT, not to just look in the CNS for pathology. I had a patient that we described with a sinus mass that turned out to be an olfactory neuroblastoma, which is a well-described cause of chronic hyponatremia from a neuroendocrine tumor. And I think you're all familiar with how we sort of diagnostically think of these patients. There are patients that are hypovolemic that have a low total body sodium and an increased total body water in relation to the sodium. Euvolemic patients who actually with SIDH are slightly hypervolemic. Their total body sodium is around euvolemic and their total body water has increased. Versus hypovolemic patients where they're both salt and water are increased, but the ratio is out of whack because of a relative surfeit of water. And again, looking again at this diagnostic algorithm and the way we think about it, we look at hypovolemics, we look at the urine sodium to differentiate patients who have primary renal salt wasting from those that are actually bona fide hypovolemia. Clearly with SIDH, usually the urine sodium is greater than 20. In patients who are hypovolemic, they can have a high urine sodium with renal disease versus a low urine sodium in heart failure and cirrhosis and so on. And again, to remember the pathophysiology of hyponatremia in say, cardiac disease, if you have a reduction in heart function, you decrease cardiac output, that'll activate ventricular and arterial receptors that turn on the renin-angiotensin-aldosterone system to increase renal sodium excretion, increase systemic resistance, and maintain your blood pressure. You'll also, however, have this non-osmotic or modulated release of vasopressin that'll cause renal water retention, increase your systemic resistance through the V1A receptors, and help sustain blood pressure. So here the side effect is that you'll have a relative excess of water reabsorption and you'll have hyponatremia. The same set of mediators get turned on in cirrhotics, and in other cases where you have a primary vasodilation that turns on the same sets of mediators and causes both an increase in vasopressin and water reabsorption, but also all these other neurohumoral activators. So where does this urine sodium of less than 20 come out? Well, there's not a lot of studies. One of the classic papers is a paper from Denver many years ago by Bob Anderson and Bob Schreier, where they both looked at patients, and I think we can assume that Bob Schreier and Bob Anderson were pretty good at examining patients. These were patients they thought to be euvolemic with hyponatremia. They gave them some saline and looked at the responders versus the non-responders in terms of an increase in serum sodium. And the responders were the ones with hypovolemic hyponatremia, and their median urine sodium was around 18. The others had much more generous urine sodiums, the one that didn't respond to saline infusion, and they had SIDH. So this key point that the physical exam is important, but it's relatively insensitive in terms of picking up patients with subclinical hypovolemia, where the urine sodium is really critical to make that assessment. If we think of SIDH, I think you're all familiar with this large differential. We think of cancers, really about 75% of cancer-associated SIDH is small cell lung cancer, but there are other cancers that can do that. Anything where you have an increase in vasopressin can give you SIDH. So if that's pain or the postoperative state, and so on and so forth. Central nervous system disorders can give you SIDH, pulmonary disorders, and drugs, we talked about SSRIs. There are other drugs that tend to get sort of put into this category but aren't really classically SIDH. So NSAIDs don't cause an increase in vasopressin, but because prostaglandins antagonize vasopressin effects in the kidney, they will potentiate any increase in circulating vasopressin. In terms of how we look at patients with SIDH, there are about 4 different patterns of the vasopressin release that we can see. One is in A, these solid circles, you get unregulated erratic vasopressin release. Here, in B, you can get a baseline increase, but a normal osmotic release. So they always have this little continual leak of vasopressin. The classic is, of course, the reset osmostat, where it's shifted to the left, and we start to see vasopressin at much lower serum sodiums and serum osmolalities. But one of the important ones that you may see on the boards, and I think we have cases that will be discussed later on, there is about 10% of patients with SIDH, if you measure their vasopressin, it's actually very low. Some of those patients have activating mutations in the V2 receptor. So there's a constitutive activation of the receptor in the absence of vasopressin. That's what's called nephrogenic SIADH, or NSIAD, which is probably the single worst acronym that was ever invented for a clinical disorder. Regardless, there are patients, though, who have increases in other mediators, such as oxytocin, that may be playing a role in this hyponatremia. So here we have a second question. It's a 19-year-old woman brought to the emergency room with altered mental status. She'd been at a rave the night before, so we think we know what's going on. She'd become drowsy at around 2 a.m. and vomited several times. At 4 a.m., she had a generalized seizure. On exam, she's unresponsive. She's now ventilated. Heart sounds are normal. She has inspiratory crackles on chest exam. Head and neck is within normal limits with no evidence of trauma. And clearly, she's got significant hypotonicity with an osmolality of 242 and a serum sodium of 121. So which of the following here is the most likely cause of this syndrome? I think we've all seen patients with ecstasy-associated hyponatremia, so we'll cut to the chase and say that that's the issue. Ecstasy is a really interesting cause of SIDH, though. Ecstasy and related drugs like Molly, they turn on serotonin, so that you end up activating the osmoreceptor neurons that are turned on by serotonergic tone. So you get all these lovely feelings from huge amounts of serotonin. The additional issue is that you turn on the osmoreceptor neurons. So really, ecstasy is SIDH in a pill form. If you give somebody a single dose of ecstasy, you can see vasopressin levels that go up to 8, which is extremely high, within a matter of hours. One of the issues, though, also is that in addition to turning on vasopressin secretion, ecstasy stimulates thirst. There was a thought many years ago that these people at raves were told to drink a lot of water, and that's partly why they became hyponatremic. There have, however, patients who presented to the emergency room where they've taken 5 tablets or 10 tablets of ecstasy as a suicide attempt and then became intensely thirsty, and in the emergency room drank 3 liters of water and became acutely hyponatremic, literally in front of the physician's eyes. So here you get an increase in vasopressin. We saw a single dose can do that with ecstasy, but there's also this acute stimulation of thirst because serotonin activates the central osmoreceptors that turn on thirst as well as vasopressin. And as I said, there has in the past been this issue of make sure you drink a lot of water. If you go to a rave, you're going to be dancing and sweating and so on. Ecstasy is also associated with rhabdomyolysis, so there was a sense that you should be very well hydrated to prevent that. This segues into a completely separate differential that we don't always talk about, which is what are the causes of acute hyponatremia where you get a sudden drop in serum sodium and sudden cerebral edema and it's really a medical emergency. And I think as nephrologists, we do appreciate that these are extremely important cases, but also extremely rare. So compared to the chronic hyponatremias that we get every other day when we're on service or when we're in the hospital, it's pretty rare to be called about an acute hyponatremic. Here in Boston, we get these every marathon day at all the various hospitals near the finish line. But in general, it's not a very common consult, somebody coming in with acute hyponatremia. Well, there's an iatrogenic group or hospital-associated group. Anybody that is post-operative, the classic studies were of premenopausal women who were getting ovarian surgery. They had a pain after the surgery, vasopressin levels went up, and somebody gave them D5 and they became acutely hyponatremic and would seize after the surgery. Any administration of hypotonic fluids with an increase in vasopressin can do it. The glycine irrigant in TURPs and uterine surgery, classically that's thought to be with a normal osmolality, but they're actually hypotonic. Colonoscopy preparation, so any form of colonoscopy purgative is associated really with hyponatremia. Particularly some of these older cocktails where, for example, somebody might put some PEG into a 2-liter bottle of something, and then that patient is becoming hypovolemic and taking in a huge amount of free water. Thiazides can cause acute hyponatremia within 24 hours of administration. And it's also a very interesting cause of hyponatremia that I think we'll talk in some of the cases later on today. Clearly polydipsia, the sort of drinking from a fire hose syndrome, that will give you acute hyponatremia. Ecstasy we talked about. Exercise-induced hyponatremia causes non-osmotic release of vasopressin, probably through some of the inflammatory mediators that get turned on when you're exercising. It's not the people that show up at the finish line at 2 hours and 10 minutes. It's the ones that straggle in at 4 hours who have been drinking too much fluid during the marathon that get into trouble. Or it can be multifactorial, say somebody's got polydipsia and takes a thiazide chronically. It's important to remember the symptoms and signs of acute hyponatremic encephalopathy. These don't really, however, follow a very ordered progression. So somebody can come in with just headache, nausea, and vomiting, and then will suddenly have a seizure. But clearly, that's about 100% of patients with acute hyponatremia. If you ask them, they do have a headache, nausea, and vomiting, or one of those 3 symptoms. You can also see that if you're very careful in patients who've got acute on chronic hyponatremia, you will find that they also have some degree of symptoms. As you get worse, you get asterixis, obtundation, and so on. You can then get seizures, dilated pupils, respiratory arrest. Afterwards, these patients can get a polyuria from a central DI and also a central diabetes mellitus. One of the key issues, though, is that really the symptom complex of acute hyponatremic encephalopathy is almost exclusively restricted to women. So if you look at the patients who have hyponatremia, there's about a 50% male and female percentage. But in terms of patients that get acute hyponatremic brain damage, almost 98% of them are female. And it's not entirely clear why. There may be more gray matter in women, so that we've got more space to expand into. There are some signaling and transport differences that are to some degree estrogen dependent, but it is still a little bit unexplained why women are much more prone to hyponatremic encephalopathy. An important issue, though, is that patients can come in with acute hyponatremic encephalopathy. A large fraction of them have very low oxygenation, and that seems to amplify the brain damage. So the more hypoxic you are, the more you get brain damage from acute hyponatremic encephalopathy. And there are two forms of respiratory failure. One is they're obtunded, so they develop a hypercarbic respiratory failure. But a very important thing to not forget is that these patients can get cerebral non-cardiogenic pulmonary edema when they come in with acute hyponatremia. This is probably similar to other forms of non-cardiogenic pulmonary edema due to increases in cerebral pressure. But this is, for example, a marathon runner who came in initially hyponatremic, clearly in pulmonary edema, and clearly with cerebral edema. And then as the sodium corrected within 24 hours, both of these abnormalities resolved. This is a patient reported from UCLA who passed away from acute hyponatremia from ecstasy. And again, this profound pulmonary edema. It can be a challenge to manage these patients because nobody wants to give a patient with a chest x-ray like this hypertonic saline, but that's really what saves the life in these patients. So again, we talked about chronic hyponatremia. The physiology of the response to chronic hyponatremia gives us this cutoff of about 48 hours. And the CNS response to hyponatremia induces sensitivity to the correction rate with respect to osmotic demyelination syndrome, as we'll talk about. Classically, a whole generation or several generations of medical students were told that chronic hyponatremia does not have any symptoms associated with it. This is partly to avoid people treating the chronic hyponatremia and causing osmotic demyelination. That pendulum has swung back over in the last decade or so, and we now know that many of these patients do have symptoms. They can have nausea and vomiting, they can have muscle cramps, they can have confusion or neuropsychiatric issues, and they can get seizures if the sodium goes down low enough. Regardless, if you have a normal brain that's exposed to a hypotonic state, you get a water gain that causes this rapid adaptation where you lose intracellular potassium and sodium, and then you get a slower adaptation where you lose the intracellular organic osmolytes that protect volume. The key problem is that the reinduction and the reuptake of those organic osmolytes is much slower than the initial response where you reduce them. So if you have an improper therapy and you rapidly correct the hypotonic state, you'll get osmotic demyelination. However, if you slowly allow the sodium to return to normal, you'll get an increase in those intracellular osmolytes and you won't get into trouble. This is what we want to avoid. It's the patients with osmotic demyelination. Classically, that's associated with central pontine myelinolysis, which is circled here for the nephrologist to recognize. These patients get flaccid quadriparesis. They can get symptoms from changes in the corticospinal tract. They can get dysphagia from corticobulbar tract. They can get a locked-in syndrome. And about 30-40% of them will have other symptoms based on other regions of the brain that are involved. They can be Parkinsonian, for example, because of problems with the thalamus. So the risk factors are the rate of correction of serum sodium, hypokalemia, partly because if you correct potassium, sodium will go up because of an exchange mechanism, alcoholism for many mechanisms, malnutrition, liver failure, liver transplantation, interestingly. You get the similar changes in cerebral osmolytes in liver failure, and if you rapidly correct that by giving a new liver, patients can get osmotic demyelination. What's interesting is, what's been a little bit mysterious is, what is the underlying pathophysiology of osmotic demyelination? And I won't go through this in great detail. Part of this is disruption of the blood-brain barrier, so many immune mediators get into the brain. You have this delayed induction of osmolyte transporters after correction of hyponatremia. For example, in the pons, that delay is particularly pronounced, and it's thought that that's why the pons is so susceptible to osmotic demyelination. There may be apoptotic or excitotoxic glutamate-dependent cell death after correction of hyponatremia. More recently, there's been this fascinating paper showing that there's the glial response to the unfolding syndrome protein causes ER stress when you overcorrect hyponatremia. So whatever the major mechanism, this really is a real issue, and it's why we're very careful to not overcorrect. And we've known this now for many decades. This is a classic paper from Rick Stearns, where they did a poll of nephrologists and collected cases over the years. Patients with chronic hyponatremia that were rapidly corrected got these chronic permanent sequelae at a higher rate, whereas the acute cases that were quickly corrected did not get into trouble. So again, this issue though of is chronic hyponatremia really that asymptomatic? This particular paper from now more than a decade ago, it was a study of hyponatremic patients at a hospital in Belgium who were thought to be relatively chronic. That they had a very high prevalence of falls. About 21% of these patients had a fall. And when they looked at patients who were hyponatremic and then corrected them, or took patients who had been hyponatremic and let them go back to hyponatremia and did gait testing and neuropsych testing, these patients had subtle gait and attention defects. So there is an underlying neuropsychiatric consequence of having chronic hyponatremia that you need to be aware of. And this issue of falls, they saw falls at every level of hyponatremia, so it wasn't really dose dependent in terms of the risk of falls. This has been seen in many other series. This is a series of thiazide-associated hyponatremia. And again, falls were quite common in these patients. And they did, however, see much more CNS complications at lower serum sodiums. And again, this theme, if we look at chronic hyponatremia, the risk of fractures is also increased if we look at large databases. Well, the initial thought was maybe that's because of this gait abnormality that you see with chronic hyponatremia. But we also now know that hyponatremia causes osteoporosis. And it's thought that the bone is a big reservoir of sodium, and as you actually release sodium from the bone, you'll modulate bone biology. If you look at rats that have been subject to this model of hyponatremia or SIDH, they have really profound osteoporosis, and we see this in patients as well. So this is something that I've adopted to my clinical practice. If I see somebody that really does have moderate hyponatremia that's chronic, I will do a bone density, and I think that is one of the major sort of chronic sequelae that we as nephrologists need to tell our internist colleagues about. In terms of treatment of hyponatremia, we'll talk about management of acute symptomatic hyponatremia in a minute. Chronic hyponatremia, clearly the cornerstone is fluid restriction. We often will give furosemide and salt tablets. Salt tablets alone also can be effective because they increase the urinary solute excretion. It gets a little tricky though to manage that or to manage furosemide and salt tablets, but it does work. Furosemide in this case is blunting the countercurrent mechanism, and you're giving salt to both increase solute excretion but also to avoid hypovolemia. Dimeclocycline is still available. It's about $10 a day. It's a principal cell toxin, and it reduces the vasopressin response. It causes AKI, however, particularly in patients with liver disease. And I think it's sort of definitely goes up and down in its use, and I think there are geographic differences in how frequently it's used. Oral urea, I'll show in a minute. I use this a lot now in my chronic hyponatremics. There's this formulation called Urena, which is sort of like Tang, and they just put it into water, and it's relatively palatable. It tastes like Kool-Aid. And the vasopressin antagonists as well play a role. In terms of the vasopressin antagonists, there are many of them, but the only two that are available in the US are tolvaptan, which is a pure V2 receptor, and conivaptan, which is a V1A, V2 receptor. And as many of you are aware, about 6 years ago now, because of the PKD trials, this chronic hepatic toxicity of tolvaptan came out and has really limited the utility of tolvaptan. We used to use it in cirrhotics quite a lot, but now most hepatologists will not use tolvaptan to manage cirrhotic-associated hyponatremia. Clearly, though, these drugs work. The SALT trials showed this, that if you gave tolvaptan, sodium corrected, and it got better and it got worse if you stopped it. Well, it's not really clear, though, where the Vaptans play a role in clinical practice. They're still very expensive. Tolvaptan is a very expensive drug. There is a risk of overcorrection. You can minimize that by frequent monitoring of serum sodium, but the key issue is that these patients cannot continue to be fluid restricted when you give them tolvaptan. Where we often use it at the Brigham is in the heart failure patients who simply cannot restrict their fluid intake any further. And this helps them correct their serum sodium and, along with diuretics, manage their severe heart failure. Again, though, this FDA advisory regarding the liver toxicity of tolvaptan limits its use to less than 1 month. In terms of oral urea, this is a great paper by Guy Decaux from several years ago that showed that oral urea is basically as effective as the Vaptans in controlling chronic hyponatremia. So these were patients that were maintained on a Vaptan with correction of their sodium. When they had a drug holiday, sodium came down. When they put them back on urea, sodium came back up. So it really does work. It's very well tolerated. You will actually be able to monitor. You'll see an increase in their BUN if they have relative renal insufficiency. But it really does work extremely well, and it's very well tolerated. In terms of acute hyponatremia, we hopefully agree that the treatment there is life-saving. You only need to increase the serum sodium by 4 to 6 points. So that has many different corollaries and consequences. First of all, if somebody came into the ED and their sodium was 114, and now it's 119, I feel a little bit reassured that even if there might have been some acute hyponatremia and cerebral edema, that has now been mitigated by that subsequent increase in serum sodium. However, if you have somebody come in with acute hyponatremia direct from the marathon, hypertonic saline is really obligatory. You do need to look at their oxygenation. It may be appropriate to do CNS imaging to see if they have cerebral edema, but you really shouldn't wait for the CAT scan to treat them with hypertonic saline if you're concerned. They need supplemental oxygen if you think that they've got non-cardiogenic pulmonary edema. Often you end up giving them a loop diuretic because it's a little bit tricky to give hypertonic saline to somebody with non-cardiogenic edema, hypertonic saline without giving them a diuretic. The key point is, though, again, this phenomenon that if you increase sodium only a few points, patients will get out of danger. So this was the Marine Corps marathon, and when they gave point of care 3% saline, they saw a relatively rapid increase in sodium, but even before that, the patients felt better from the hypertonic saline. The rate of correction is not entirely clear. In acute hyponatremia, we probably should increase it by 1 to 2 milliequivalents per hour. There is now, however, this trend to give them a bolus of hypertonic saline right up front, as I'll mention in a minute. In terms of chronic hyponatremia, the classic recommendation is 0.5 milliequivalents per hour, less than 10 in 24, and less than 18 in the first 48 hours. If you look at up to date, though, Rick Stearns and many other people advocate a much more conservative correction, particularly in patients that we think are at risk for osmotic demyelination. Again, this trend now to give a bolus of hypertonic saline. So this compares the sodium in the red from a bolus of 100 mLs of hypertonic saline versus patients that were given, I think, 30 mLs per hour over a period of time. Sodium came up much quicker in the patients that were given the bolus, but also their Glasgow Coma scale seemed to increase more quick in the patients that were given a bolus. If you do decide to give a chronic infusion, there are many different formulas for calculating the initial saline infusion rates. These, however, are really not all that helpful because as you start to give patients with hyponatremia saline, you do start to see that physiological response, So it's very hard to bake that into a formula that helps you decide. So this was shown in Rick Stern's group many years ago, that if they looked at the rate of correction in patients, the Droege-Medias formula underestimated that correction almost 80% of the time. You can use the sodium deficit calculation to decide how much of hypertonic saline. The rule of thumb is each delta of 1 milliequivalent requires about 70 mLs of hypertonic saline. The key point, though, is we now are pretty comfortable about both increasing serum sodium if we need to and reducing it if we need to. So if you overcorrect, you can give DDAVP and D5W to re-induce hyponatremia. There's both animal and human data that can help in patients with osmotic demyelination. At some point, we may start giving myo-inositol supplementation that's relatively benign, and it's one of these key intracellular osmolytes in the brain that plays a role in ODS. There is also some evidence in some human case reports of giving dexamethasone to help correct the blood-brain barrier defect that we see in osmotic demyelination. There's animal data and these occasional case reports, but it's not yet recommended. But what we can do, though, is we can re-induce hyponatremia. And this used to be recommended many years ago, but there wasn't a lot of clinical data that this was actually safe. There was a large case series, though, now 10 years ago, published by Rick Stern's group, that showed it seemed to be relatively safe to give people vasopressin back and to give them free water and reduce their serum sodium. Remember that many of the patients that overcorrect do so because the vasopressin goes away rapidly, and then they start to have this water diuresis. The problem, though, is you get this kind of herky-jerky up and down, and it gets very hard to regulate that. If you get involved in these patients up front, you can sort of clamp vasopressin activity by giving high-dose DDAVP and maintaining it by giving either TID dosing or BID dosing, and then sort of fill the beaker with hypertonic saline. And ideally, you get this nice linear increase in serum sodium as you correct at an appropriate rate. So in the interest of time, I'll skip this case. However, this additional third differential comes into play. These are the patients that get hyponatremia that is associated with overcorrection. And again, this is any form of hyponatremia where vasopressin can really rapidly disappear. So with hypovolemic hypernatremia, if you give saline and vasopressin disappears, you can get an acute water diuresis. If you have hypopit with a secondary adrenal failure, if you give cortisol, vasopressin levels come down and you can get overcorrection and so on and so forth. So here, this is looking at patients with secondary pituitary disease and secondary adrenal failure. If you look at their vasopressin pre and post giving them dexamethasone, you see this rapid drop in vasopressin in patients that were given it. This is a case that we had at the Brigham where the patient was given high-dose glucocorticoid and had a rapid overcorrection of serum sodium in that setting. So in the last few minutes, we'll talk a little bit about hypernatremia. There are additional cases that Dr. Yu will present, and I think I have a case that we talk about later on. But here the issue is either an increase in the numerator, a high level of sodium, which is relatively rare, but more commonly a decrease in the denominator, a reduction in total body water through various mechanisms. So this is due to water intake disorders typically. An insufficient water intake is very common, particularly in elderly patients. High sodium intake without adequate water is rare. We do see that in the hospital, though. Patients that are given, for example, multiple boluses of sodium bicarbonate, which is has twice the tonicity of hypertonic saline, you can see an increase in their serum sodium because of that. Thirst or osmoreceptor lesions are a relatively rare cause of hypernatremia, but they do occur. Part of the issue is that there's a redundancy of these osmoreceptor neuron networks, so you really have to hit many of them to cause a defect. They can occur, though, for example, with infiltrating CNS tumors, granulomatous disease. We had a case a few years ago at the Brigham from sarcoidosis. Ischemia or a stroke, primary hyperaldosteronism can do it. And with advancing age, the osmoreceptor neurons lose some degree of function. Many patients will also have an inappropriately high water loss that causes hypernatremia. This can be insensible losses in sweat and breath. Gastrointestinal losses. Remember that secretory diarrhea tends to be isosmotic, whereas osmotic diarrhea tends to cause free water loss, or renal loss of free water. Here then we're talking about diabetes insipidus, either central DI or gestational DI, where there's an increase in degradation of vasopressin, or renal vasopressin resistance and nephrogenic DI, and classically seen in patients with lithium treatment. In terms of causes of central DI, these can be pituitary surgery or head trauma, tumors, stroke, etc. We talked about sarcoid can cause central DI as well as an osmoreceptor defect, or there can be hereditary causes due to defects in the actual vasopressin gene. We're classically told that there's this triphasic response of serum sodium after pituitary surgery, but really the triphasic response is seen in a relative minority of patients with central DI after pituitary surgery, and there are many different patterns that you can see. In terms of polyuria, that's defined as greater than 3 liters per day of urine output. The key differentiating feature is the osmolar excretion rate. If it's greater than 1,000 per day, that's an osmotic diuresis, classically due to salt, glucose, urea, or mannitol if it's administered. Less than 1,000 milliosmoles per day is typically a water diuresis. And if they have a serum sodium greater than 140, you think of diabetes insipidus. If it's less than 140, you think of polydipsia. There are many causes of nephrogenic DI, genetic causes, drug-induced. Really, lithium is the single most common cause of drug-induced nephrogenic DI. There's also a cellular defect, however, and if you look at patients with ATN, for example, I think many of you will appreciate that 2 or 3 days after the renal function improves, we'll see slight hypernatremia in patients who have that post-ATN diuresis and that post-ATN concentrating defect due to a cellular defect. Gestational DI is a very interesting cause. It's about 1 in 300,000 pregnancies. These patients have an increased activity, an expression, and release of the vasopressinase that's produced by the placenta. And this may occur in the context of preeclampsia and/or acute fatty liver or pregnancy. These patients will respond to DDAVP because it's resistant to the vasopressinase and hence effective. One of the interesting things is you'd think that this phenotype would disappear very quickly after pregnancy, but it actually can last for 2 or 3 months after pregnancy. So these patients may need DDAVP therapy for quite some time. Classically, we used to do water deprivation testing to look at whether patients had an incomplete nephrogenic DI or central DI and so on. More recently, however, there is the measurement of copeptin. So copeptin is co-secreted with vasopressin and neurophysin 2, so it can be measured in the serum as an indicator of vasopressin levels. It's much easier to measure, it has a longer half-life, and the measurements are much more sensitive. So if we have somebody who's got a polyuria polydipsia syndrome, we can measure random copeptin. If it's greater than 20 or so, that suggests a nephrogenic DI. If it's less than 20 or so, that suggests a central DI. And we can then look at stimulated copeptin in the setting of giving them hypertonic saline, and if you stimulate it, don't stimulate it, then that's a central DI, whereas if you do stimulate an increase, that's what you see with primary polydipsia. To my mind, though, this has not really become generally available. Most hospitals, certainly our hospital, does not yet have plasma copeptin assays, but that should come out relatively soon, one would hope. In terms of treatment of hypernatremia, the key issue is to restore the water deficit, to reduce and or replace ongoing loss of hypotonic fluids. And that tends to be forgotten, for example, in patients with nephrogenic DI, where they may be losing 1 to 2 liters per day of free water. We tend to forget that that also needs to be replaced. We then think of treating the underlying cause, whether it's DDAVP for central DI, Nephrogenic DI can be treated with hydrochlorothiazide, although I almost never do that. NSAIDs can also help with that. Again, I don't typically do that. And we talked about gestational DI, where you can give DDAVP. One interesting question is the correction rate. We've been classically told that it should be less than 0.5 mils per hour. In reality, though, there's a paper that came out just this spring that suggested that the rate of correction of hypernatremia in critically ill patients did not really impact on mortality and morbidity. So it's not clear, unlike in hyponatremia, whether rapid correction is as bad as we might think. The quantitative formulas that are important, first of all, is to calculate the free water deficit, but then also use the electrolyte free water clearance as an indicator of how much water these patients are excreting per day, and then correct that free water deficit, but also replace ongoing losses. So the take-home messages that I wanted to underline today: first, this role of central osmoreceptors in hyponatremia, the differential diagnosis of acute hyponatremia and hyponatremia prone to overcorrection, which we tend to forget about. The role of DDAVP and D5W in patients who've overcorrected, and the role of the DDAVP clamp with hypertonic saline to provide a more controlled correction. We talked about the use of oral urea in SIDH, and we emphasized this issue of electrolyte-free water clearance in hypernatremia to estimate the ongoing loss. So I had a issue of Seminars in Nephrology that is now 10 years out of date, but actually hasn't changed all that much. Feel free to let me know, and I can give you, it's about 100 pages of all you can read about hyponatremia and didn't ask to read. And we've talked about some of the other classic papers as we went along.